Nick Majerison here. Welcome to Top Men Talk. This is part 3 of a short series of podcasts where we're looking at the proactive care for older people undergoing surgery team, or POPS team, that are based in Guy's and St Thomas's Hospital in London, England. Here, Dr Jugdeep Dhesi explains how the Frailty Unit works to Monty, Mythen and Desiree, Chappell. Have a listen.
Top Men Talk. Jugdeep, I heard that you've got a frailty unit in your emergency room here, your A&E. Tell us a little bit about that.
Yes, so we've set that up over the last probably 12 to 18 months now, and it's gone through a number of iterations over that time. But we're now based down in A&E. We've got a set of recliner chairs and then a number of trolleys. So it's not a kind of bed-based unit as such. Patients who are frail with specific conditions when they turn up at A&E, so things like an episode of delirium, a urinary tract infection, a fall, or an exacerbation of a long-term condition, move directly into the Frailty Unit, which is a consultant-led unit, but with therapy staff, pharmacy support, and a junior doctor who's predominantly there for training. And so patients who are seen there, our aim is to effectively support them in terms of their long-term condition and to ensure that they can have a safe and effective discharge directly from A&E home.
I think you were just sharing a story with us that one of your colleagues had seen, I think it was 9 patients. And how many of them did she manage to get back home?
So our shifts down there are at a weekend. So this was at the weekend just gone. She had run a shift from 11 in the morning till 8 in the evening. And in that time had seen 9 patients, all of whom were pretty complex, frail, older patients. And 8 of those patients were discharged directly home, but with the appropriate services inputted both from social care, rehabilitation, but then having access to what we call hot clinics here, where patients can then be reviewed back in a very timely fashion to make sure that it has been a safe and effective discharge.
That sounds fantastic for everyone. That sounds wonderful for the patient, wonderful for the family. Huge contribution to the challenges of the acute hospital. So is everyone going to have one soon, or is it slow coming?
It's actually picking up pace, really. So frailty units are starting to appear at a lot of hospitals, and certainly we weren't the first to start this. There have been a number of units which have been running very effectively around the country already. And I think it's about us kind of learning lessons from units which are already established, not reinventing the wheel, getting the pro formas that they already use, their policies, adapting them to your local context, and then getting up and going, not waiting to develop the perfect pathway, but getting it going and then constantly changing it and reviewing it in a constructively criticising your own service and looking at the data, changing it as you go along. So they are coming at pace, Monty. There's lots of units starting to appear around the country. I think you do need to have geriatricians directly leading those services. And again, that's another challenge to us in terms of the workforce. But a lot of the work is delivered by nursing colleagues, allied health professionals.
So from a relative's perspective, it must be wonderful to know that you can take your frail elderly loved one to the hospital, to what looks like the A&E environment, and know that there's a very real chance that they'll be coming home with you again. That must be wonderful.
It is wonderful, and I think most patients and families, carers are, that's exactly what they would like to see happening. But at the same time, I think there is a public perception that patients with frailty and with complex multimorbidity are best served in the hospital as well. So there is some work that we need to do around empowering patients, their families, their carers, and starting to help really facilitate that kind of understanding about where the best place for care is, which clearly is sometimes a hospital. We shouldn't be denying this group of patients acute hospital-based care where appropriate, but there is some work to be done around kind of public understanding of the effectiveness of an early discharge home.
Absolutely. I think we're possibly in a privileged position where we've seen all the different alternatives. And if at all possible, home is best. I mean, Desiree, from the US perspective at the moment, what's happening with the frail and elderly in these situations?
We don't have frailty units, that's for sure. Most places, the idea of that and concept is fantastic, and I think could really change the way. I mean, we have changed the triage situation in some of our A&Es, but discharging home is definitely the best thing for patients, and getting them in and out of the hospital in a quick way and taken care of. I think we have totally changed the way we send patients home. If they do have a stay in the hospital, instead of going to rehab, they're able to be discharged home. So that's great. But we're going to wrap up today. Thank you, Jugdeep, so much for joining us.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, and don't forget this is part 3 in a 4-part series based around the proactive care for older people undergoing surgery team, or POPs for short, based in Guy's and St Thomas's Hospital in London, England. If you want to hear the other parts of this series, all you need to do is get to the website topmedtalk.com. That's topmedtalk.com.